Good evening. Greetings from Sri Lanka and Colombo and the Ceylon College of Physicians. And first of all, let me thank the Pakistan Society of Internal Medicine, Dr. Somia, Dr. Jawad Akram, and all the people who have been instrumental in inviting me to this beautiful place in Karachi. So what I plan to do during these 20 minutes is to give you a practical update based on several cases on thyrotoxicosis. These are the broad objectives. And I have looked into some data, and it looks like that based on this study from India, nearly about 2% of the people in the population have active thyrotoxicosis. So it's not an uncommon problem. So let's start with a case. 35-year-old woman presenting with weight loss, appetite, increased appetite, excessive sweating, palpitations, very low BMI, warm moist palms, tachycardia, and a goiter. And anybody would say what this is. So this is typical symptomatic Graves' disease with orbitopathy. So in this scenario, we need to confirm biochemically thyrotoxicosis. One would say that you don't need because this is obvious, but particularly when you titrate, we need to have some basis. So we need to biochemically have parameters set in. Then again, in thyrotoxicosis, although this is very obvious in this case, we need to determine the exact etiology, which is also very important in the further management and then institute appropriate therapy. So the diagnosis is the best. The test is to do TSH, and particularly if the machines and the lab can reflexively do the free T4 and T3 automatically if the TSH is low, that is the best way. But most of our labs would not do that. So usually at the baseline, any patient being suspected of thyrotoxicosis or thyroid disease, generally at least TSH and free T4 is a must to miss out rare but important conditions. T3 is optional, but again, in a situation where there's suppressed TSH and normal T4, you might need T3 as well. Even if the TSH is normal or high, if the thyrotoxicosis is suspected, then you might definitely need to do free T4 and T3. I will tell you why that is as we go on. So in this patient, there's obvious thyrotoxicosis. So what are the other further investigations you need to do? Generally, as I said, might not need many things because we know the diagnosis, but doing thyroid receptor antibodies is a useful test, particularly in people, because that high titer would predict whether the patient would go into spontaneous remission when you treat these patients, and also particularly in a childbearing woman, whether if the woman gets pregnant, whether the neonate and the fetus would have thyrotoxicosis is also predicted by TRAB. So doing TRAB can be useful because of these reasons. So we know all that thyrotoxicosis is a clinical state of elevated thyroxine in the circulation. This can be due to the increased synthesis where it is true hyperthyroidism, but sometimes this can be also due to excess release as in the thyroiditis. And these are the common causes of hyperthyroidism. Graves is still the commonest cause, followed by the nodular goiters like toxic multinodular goiter, toxic adenoma, then thyroiditis, amiodarone-induced thyroid disease. And then sometimes we see patients due to extrathyroidal causes, either iatrogenic or factitious. Struma is a very rare cause, and then the TSH-mediated causes are also rare, the TSH hormone and thyroid hormone resistors. So the clinical features can be explained by increased basal metabolic rate and increased sensitivity for the sympathetic nervous system. And there are many cardiovascular, skin, neuropsychiatric, general, GIT, musculoskeletal, including rare periodic paralysis and reproductive issues, the reduced libido, sexual dysfunction, problems in menstruation, all can happen with thyrotoxicosis. And in Graves, in addition to the effects of thyroid hormones, we know there's inflammation of the retrobulbar tissues, both the muscles and the soft tissues, leading to chemosis, proptosis, exophthalmos, and so on. And this is a typical picture with a diffuse goiter and eye signs, and sometimes it can be very severe, even leading to vision loss, and a lot of dermatological manifestations like onycholysis, and although rare, we see this very troublesome pretibial myxedema sometimes in patients with Graves' disease. So just to take you through, particularly this might be useful to trainees, how we should look into the etiological diagnosis of thyrotoxicosis. If there are, first of all, you need to see whether there are features of Graves, which are the new onset eye signs, non-nodular goiter, moderate to severe thyrotoxicosis. In that case, usually likely in this case, the Graves is very, very highly possible. If not, we need to see whether there's a nodular goiter. If not, measuring thyroid receptor antibodies can be useful, and if positive, again, Graves can be confirmed. If not, we need to generally do either uptake scan or thyroid ultrasound with Doppler measurements, and even if the antibodies are negative, this may be the route that we need to undertake. Then if we choose the uptake scan, if it is high or normal, the possibilities are the Graves' disease, then toxic adenoma and the toxic multinodular goiter, which have the unique appearances. And if it is low or absent, we need to think of the thyroiditis, factitious thyrotoxicosis, and struma orii. If we choose thyroid ultrasound and the Doppler flow, if the flow is high, it's usually Graves, low thyroiditis. Normal can be Graves, so you need to perhaps do more tests to identify, like the uptake scan. Anti-TPO antibodies can be complementary in situations where there is thyroiditis. So this is the typical diffuse increased uptake of our patient, and this is what's called the thyroid inferno, the very angry looking increased vascularity in patients with Graves' disease if you do the Doppler. And based on the patterns of thyroid functions, you can label patients. Any form of primary hypothyroidism, the TSH is suppressed. If both T4 is and T3 is low, you will see the typical thyrotoxicosis. And if the T4 is normal but T3 high, we call it T3 toxicosis. And if it is inverse, we call T4 thyrotoxicosis. And if both normal with suppressed TSH, we call it subclinical hyperthyroidism. And then if TSH, T4, T3, all are low, it's TSH dependent conditions like TSH-OMA or resistance. And sometimes in patients with non-thyroid illness and in patients with hypothyroidism but critically ill, we see this pattern with slightly low TSH, low T3, normal T4. So these are the various patterns we encounter in patients with thyrotoxicosis. So in the management, usually these patients who are very symptomatic need symptomatic treatment to protect their cardiovascular system. Particularly, beta blockers are very useful unless contraindicated in patients with asthma, COPD, in which case we can use drugs like diltiazem and verapamil. We need to stop symptomatic treatment once the patient has euthyroid. The specific treatments are the thionamides, radioactive iodine treatment, and surgery. They have their usual advantages and disadvantages. The antithyroid drugs, they are low cost, less, and also the less apprehensive and more acceptable to patients, and they have chance of spontaneous sustained remission, and then it won't lead to permanent hypo. The disadvantages are mainly the troublesome side effects like the serious agranulocytosis, hepatotoxicity, lupus-like syndrome, and the fetal toxicity that can happen. Coming to radioactive iodine, it can lead to permanent resolution of hypothyroidism, but Many issues can happen with permanent hypo, and then radiation precautions can be troublesome for some people who cannot get isolated. Then some people can be concerned, although there's a lot of data, so that is very safe. Some people are still afraid. Surgery, again, very good for permanent resolution of hypothyroidism, quick action, and particularly useful for people who cannot have radioactive iodine treatment, as well as who are intolerant to the drugs. The issues are sometimes you can get hypoparathyroidism and surgical complications and initial high cost. So the antithyroid drugs we usually use for 1 to 2 years, anticipating spontaneous remission in Graves, and usually in any thyrotoxic condition to achieve euthyroidism before surgery or I-131. We know the carbimazole and the product methimazole are the preferred drugs because of their safety. PTU is available, but specific indications are there, which I will come into shortly. And generally, we start with high dose and taper gradually, and the usual doses are carbimazole around 45 maximum and methimazole around 30. For PTU, the specific indications are the first trimester of pregnancy, thyroid storm, and then people who are having minor reactions to carbimazole or methimazole, we might tend to use PTU. We need to warn patients about the side effects, how to identify them, and come back to us. Baseline tests can be useful because you know what had been there in the baseline, but not essential. Again, routine follow-up counts and LFT is not indicated unless there are problems. Minor reaction can continue with symptomatic treatment, and there can be cross reaction. There is a lot of emerging evidence and meta-analysis that have shown that long-term low-dose anti-thyroid drugs are useful and effective, and also leads to higher incidence of spontaneous remission, and is being adopted more frequently than in the past. And in patients who are either intolerant to the antithyroid drugs or have very severe disease, there are useful other agents that we use. The Lugol's iodine particularly prevents release of thyroid hormones. Lithium carbonate again can be useful, and cholestyramine, which interferes with the enterohepatic circulation. Radioactive iodine treatment can be done for primary therapy for Graves or relapsed Graves, toxic adenoma, and toxic multinodular goiter. We need to exclude pregnancy not indicated in lactation. Usually, it's useful to normalize thyroid functions, except in the mild disease. Generally, we need to withdraw the antithyroid drugs 1 to 2 weeks before radioactive iodine treatment, and a lot of counseling. Looking into contraception can be important. Coming to the next scenario, older person with hypertension comes with slightly suppressed TSH, normal free T4, no symptoms. I think everybody would know that this is subclinical hyperthyroidism, although certain other conditions can also give this pattern. Subclinical hyperthyroidism, as we know, is low TSH with normal thyroid hormones, can progress to overt hyperthyroidism, particularly when the TSH is very low. It can be associated, particularly in the older people, with adverse outcomes, particularly atrial fibrillation, heart failure, osteoporosis, and dementia. Because of that, there are specific indications for the treatment for subclinical hyperthyroidism. When the TSH is very low, most of the time, except in the younger asymptomatic patients, it is recommended to treat. When the TSH is not so low, between 0.1 to 0.5, generally people who are above 65 or having cardiovascular comorbidities are recommended for treatment. Otherwise, young people, osteoporosis, generally not recommended by the ATA. Coming to another case where a patient has presented like a PUO-like picture, fever, body aches, loss of weight, painful swallowing, with high inflammatory markers, high ESR, low HB, high platelet, tender goiter. I think most of you agree that we are dealing with subacute or decovenous thyroiditis. I have seen many patients presented like PUO. Here is the thyroid bed. You see there is no uptake here. There is some uptake in the salivary gland. So this is a typical pattern of thyroid uptake in patients with thyroiditis. So there's a lot of symptoms, pain, fever, and there's features of thyrotoxicosis, and they can later on go into hypothyroidism. We usually treat thyroiditis, thyrotoxicosis with symptomatic treatment because the thyroid gland is not active. Anti-inflammatory therapy, sometimes steroids can be useful for the pain and other symptoms. And as I said, some may progress to hypo. Hypothyroidism occurring in pregnancy can be really troublesome, and overt hyperthyroidism is associated with adverse maternal and fetal outcomes. PTU is preferred in the first trimester, but we need surveillance for fetal and neonatal hypothyroidism, particularly with Graves. Radio uptake scans and I131 definitely contraindicated, and the people who are intolerant to drugs can be offered thyroidectomy in the second trimester. You need to distinguish the overt hypothyroidism in pregnancy from gestational thyrotoxicosis or hyperthyroxanemia of pregnancy, where the overt hypothyroidism is more severe symptomatic. There can be a goiter, particularly with if with Graves, bruit and eye signs, and the positive TRAB can be there, and usually does not spontaneously resolve, but can improve in the second trimester and beyond, and that need treatment compared to gestational thyrotoxicosis. Coming to another case, 35-year-old woman, you see the TSH is high, just above normal, T4 is elevated, T3 elevated. So what are the possibilities unless the patient has been on any other treatment or any other condition? So this is the typical picture you get in TSH mediated hyperthyroidism, TSHoma, not common, but we see that particularly as endocrinologists, and thyroid hormone resistance are the other causes. Coming to another case, 65-year-old man presenting with this is actually one of the cases I saw a few months ago, real case, high fever, confusion, fever for 1 week, wasted, had bilateral ankle edema, diffuse goiter, was in atrial fibrillation, very wide lowish blood pressure, elevated JVP, enlarged heart, there were fine crackles in the lung bases. Initial investigation did not show evidence of infection except for mild leukocytosis and slightly deranged LFTs, CRP, procalcitonin, ESR, and the lumbar puncture all were normal. So what's the diagnosis? This is thyrotoxic crisis, or we call it thyroid storm with thyrotoxic cardiomyopathy. It was diagnosed, the ejection fraction was 40. And we know that thyroid storm is a rare form of extremely severe thyrotoxicosis associated with high mortality unless you promptly diagnose and treat. So you need a high index of suspicion to detect this. So you need a lot of general measures, cooling to reduce temperature, sometimes broad spectrum antibiotics if you are not sure whether there is ongoing infection, oxygen, beta blockers, sometimes IV beta blockers, IV furosemide, anticoagulation if the patient is having AF. PTU is the preferred drug in thyrotoxic crisis because it also inhibit the conversion of T4 to T3 in the circulation. IV hydrocortisone again reduce peripheral conversion, and also some of these patients might have adrenal insufficiency. Lithium carbonate, cholestyramine, and Lugol's iodine actually were also used in this patient. Patient made uneven recovery, and the cardiac status improved markedly. Another important thing that I have seen is that these patients who get thyrotoxic cardiomyopathy, if they tolerate the drugs and improve, you should not push them for definitive treatment soon, because particularly for radioactive iodine ablation, you might have to take them off antithyroid drugs, and then during this period they can go into a relapse, and also they might not have sufficient cardiovascular fitness for undergo surgery. So another patient, 77 man, wrote with a complaint of being less active, reducing memory, constipation, examination otherwise unremarkable, pulse was more or less normal, and so everybody might agree that this is the typical picture that we see in most patients with hypothyroidism. A GP has suspected hypothyroidism, but the pattern was completely different. So TSH is suppressed. Actually, this is not 0. It's 2.6. So elevated T4. So this is called the apathetic hyperthyroidism we see in older patients. So we need to understand that older people can present with typically not the common picture of hyperthyroidism, the picture of hypo. So ladies and gentlemen, in summary, thyrotoxicosis is a common medical problem, ranges from subclinical to the thyroid storm. Early diagnosis is very important to improve outcomes, and the rational use of diagnostic tools and therapeutic modalities will improve patient outcomes, and low dose long-term ATD strategies emerging. And thank you very much, and I would like to invite you all for the annual sessions of the Ceylon College of Physicians in September.